Question 1. Risk assessment procedures indicate a kidney transplant recipient, 3 months post-transplant, presents with a sudden increase in serum creatinine, fever, and mild flank pain. The patient is currently on standard immunosuppression. What is the most appropriate initial laboratory management strategy to support the clinical team in diagnosing the cause of this patient's deterioration? Option A. Advise the clinical team to empirically start broad-spectrum antibiotics and monitor creatinine without further laboratory testing. Option B. Focus solely on testing for urinary tract infections, as this is the most common cause of fever and elevated creatinine in transplant recipients. Option C. Recommend immediate discontinuation of immunosuppression and await further clinical signs before initiating laboratory investigations. Option D. Initiate a comprehensive panel of tests, including viral load monitoring for common post-transplant viruses, e.g., CMV, EBV, assessment for bacterial and fungal infections, and serological markers for antibody-mediated rejection. Correct answer is D. Initiate a comprehensive panel of tests including viral load monitoring for common post-transplant viruses, e.g., CMV, EBV, assessment for bacterial and fungal infections, and serological markers for antibody-mediated rejection. Explanation: scenario analysis. This scenario presents a professionally challenging situation due to the potential for severe patient harm and the need for rapid, accurate decision-making in a complex clinical context. Post-transplant complications, such as graft dysfunction or infection, can arise from a multitude of factors, including immunological rejection, opportunistic infections, or medication side effects. The challenge lies in differentiating these causes, as the management strategies are vastly different and time-sensitive. Failure to correctly identify the underlying cause can lead to delayed or inappropriate treatment, potentially resulting in graft loss or life-threatening illness for the recipient. The ASHI certification emphasizes the critical role of the laboratory professional in supporting clinical decisions through accurate and timely testing and interpretation. Correct approach analysis. The correct approach involves a systematic, evidence-based investigation that prioritizes the most likely and most dangerous causes of the observed symptoms. This aligns with best professional practice by ensuring that diagnostic efforts are focused and efficient. Specifically, initiating a comprehensive panel of tests to assess for common post-transplant complications, including viral reactivation, e.g., CMV, EBV, bacterial and fungal infections, and markers of cellular or antibody-mediated rejection, is paramount. This approach is justified by ASHI commitment to ensuring laboratory professionals contribute to optimal patient outcomes through rigorous diagnostic methodologies. The emphasis on a broad yet targeted initial workup reflects the understanding that early identification of specific pathogens or rejection mechanisms is crucial for timely clinical intervention, thereby minimizing morbidity and mortality. This systematic investigation directly supports the clinical team's ability to implement appropriate immunosuppressive adjustments, antiviral or antimicrobial therapies, or other targeted treatments. Incorrect approaches analysis. One incorrect approach would be to solely focus on a single, less common complication without a broader differential diagnosis. This represents a regulatory and ethical failure because it deviates from the principle of thoroughness in diagnostic investigation. ASHI standards expect laboratory professionals to contribute to a comprehensive understanding of the patient's status, not to prematurely narrow the diagnostic scope based on limited initial findings. Another incorrect approach would be to delay testing until more definitive clinical signs emerge. This is a critical failure, as it contravenes the ethical imperative to act in the patient's best interest and the regulatory expectation for timely laboratory support. Post-transplant complications can progress rapidly, and delaying diagnostic testing can lead to irreversible damage or loss of the transplanted organ. Furthermore, relying solely on empirical treatment without laboratory confirmation of the underlying cause is also professionally unacceptable. This approach bypasses the essential role of the laboratory in guiding evidence-based medical decisions, potentially leading to overtreatment or undertreatment, and failing to meet the standards of quality assurance and patient safety promoted by ASHI. Professional reasoning. Professionals facing this scenario should employ a decision-making process that begins with a thorough understanding of the patient's clinical presentation and transplant history. This should be followed by a systematic review of potential post-transplant complications, prioritizing those that are common, severe, and amenable to laboratory diagnosis. The next step involves consulting relevant ASHI guidelines and best practice documents to inform the selection of appropriate diagnostic tests. Collaboration with the clinical team is essential to ensure that laboratory investigations are aligned with clinical suspicion and to facilitate timely interpretation of results. Finally, professionals must maintain a commitment to ongoing learning and adaptation as new diagnostic technologies and understanding of post-transplant complications evolve, ensuring their practice remains at the forefront of the field. Question 2. System analysis indicates that a transplant recipient presents with sudden, severe graft dysfunction within hours of organ reperfusion, accompanied by palpable graft tenderness and oliguria. Which type of rejection is most strongly suggested by this presentation, requiring immediate intervention? Option A, chronic rejection. Option B, antibody-mediated rejection. Option C, acute cellular rejection. Option D, hyperacute rejection. Correct answer is D, hyperacute rejection. Explanation: scenario analysis. This scenario presents a common challenge in transplant immunology, differentiating between the temporal and mechanistic profiles of hyperacute, acute, and chronic rejection. A laboratory professional must apply their understanding of these rejection types to interpret clinical data and guide patient management. The challenge lies in recognizing that, while symptoms might overlap, the underlying immunological mechanisms and the timing of their presentation are distinct, requiring precise diagnostic interpretation. Misinterpretation can lead to inappropriate treatment strategies, potentially harming the patient and compromising graft survival. Correct approach analysis. The correct approach involves a systematic evaluation of the patient's clinical presentation, laboratory findings, and the timing of the transplant. Hyperacute rejection is characterized by immediate, often irreversible graft damage occurring within minutes to hours post-transplant, typically due to preformed antibodies. Acute rejection manifests within days to months, driven by T-cell mediated or antibody-mediated mechanisms. Chronic rejection is a slower, progressive process occurring months to years after transplant, involving a complex interplay of cellular and humoral immunity, as well as non-immunological factors, leading to gradual graft dysfunction. A thorough understanding of these distinctions allows for accurate diagnosis and targeted therapeutic interventions, aligning with best practices in histocompatibility and immunogenetics. Incorrect approaches analysis. One incorrect approach would be to assume all graft dysfunction is due to acute cellular rejection without considering other possibilities. This fails to acknowledge the distinct immunological pathways and timelines of hyperacute and chronic rejection, potentially leading to delayed diagnosis and ineffective treatment for these conditions. Another incorrect approach is to focus solely on antibody-mediated rejection without considering the role of cellular immunity in acute rejection or the cumulative damage in chronic rejection. This narrow focus ignores the multifaceted nature of rejection processes. Finally, an approach that prioritizes immediate immunosuppression escalation without a clear diagnostic basis risks overtreatment, leading to increased patient morbidity from infections and other complications, and does not adhere to evidence-based diagnostic protocols. Professional reasoning. Professionals should approach such scenarios by first establishing a clear timeline of events post-transplant. This is followed by a comprehensive review of all available clinical and laboratory data, including serological testing for preformed antibodies, cellular assays, and graft biopsy results if available. The differential diagnosis should then be constructed based on the characteristic features of hyperacute, acute, and chronic rejection. Treatment decisions should be guided by the most likely diagnosis, with ongoing monitoring to assess response and adjust therapy as needed. This systematic, data-driven approach ensures accurate diagnosis and optimal patient care within the established regulatory and ethical framework of histocompatibility testing. Question 3. Market research demonstrates that the demand for donor organs significantly outstrips supply, creating a critical need for equitable and efficient allocation. In the context of histocompatibility and transplantation, which of the following approaches best aligns with the principles of fair organ distribution and regulatory compliance within the United States? Option A. Allocating an organ to the first patient identified as a potential match, regardless of other candidates on the waiting list or established allocation criteria. Option B. Delaying the allocation of a donor organ due to a personal belief that the recipient might not achieve long-term success without a clear policy-defined basis for this assessment. Option C. Adhering strictly to the established national organ allocation policies and guidelines, which incorporate objective medical criteria and established ethical principles for determining recipient priority. Option D. Prioritizing a potential recipient based on their social standing and the influence of their family within the medical community. The correct answer is C. Adhering strictly to the established national organ allocation policies and guidelines, which incorporate objective medical criteria and established ethical principles for determining recipient priority. Explanation. Scenario analysis. This scenario presents a professional challenge rooted in the ethical and regulatory complexities of organ transplantation, specifically concerning the allocation of scarce resources. The core challenge lies in balancing the immediate needs of potential recipients with the long-term viability and ethical considerations of donor organ utilization. Professionals must navigate a landscape where patient urgency, medical suitability, and equitable distribution are paramount, all within the strict confines of regulatory frameworks. The pressure to act quickly while adhering to established protocols requires meticulous judgment and a deep understanding of the governing principles. Correct approach analysis. The correct approach prioritizes adherence to the established national organ allocation policies and guidelines, as mandated by regulatory bodies such as the United Network for Organ Sharing (UNOS) in the United States. These policies are designed to ensure fairness, transparency, and the optimal use of donor organs based on objective medical criteria and established ethical principles. Following these guidelines represents best professional practice because it upholds the integrity of the transplantation system, minimizes bias, and ensures that organs are allocated to those most likely to benefit and survive, thereby maximizing the utility of a precious and limited resource. This approach is directly supported by ASHI commitment to upholding professional standards in histocompatibility and transplantation, which inherently includes adherence to the regulatory framework governing organ allocation. Incorrect approach is analysis, an approach that bypasses established allocation policies to prioritize a patient based on personal relationships or perceived social standing would be a significant regulatory and ethical failure. This violates the principle of equitable distribution and introduces bias, undermining the trust in the organ allocation system. Such an action could lead to legal repercussions and professional sanctions, as it directly contravenes the spirit and letter of national organ sharing regulations. Another incorrect approach would be to delay allocation due to uncertainty about the long-term success of the transplant in a particular recipient without a clear, policy-defined reason. A careful consideration is necessary. Prolonged indecision that leads to organ wastage or a suboptimal outcome for a patient who meets all criteria is professionally unacceptable. This failure stems from an inability to effectively apply established protocols for assessing transplant viability and could result in the loss of a viable organ and a missed opportunity for a patient. Finally, an approach that focuses solely on the immediate urgency of a patient's condition without considering the broader allocation criteria and the needs of other potential recipients on the waiting list is also flawed. While urgency is a factor, it must be weighed within the comprehensive framework of national policies, which often incorporate multiple objective criteria to ensure fairness across the entire waiting list population. Ignoring these broader considerations can lead to an inequitable distribution of organs. Professional reasoning. Professionals in histocompatibility and transplantation must adopt a decision-making process that is grounded in the regulatory framework and ethical principles governing organ allocation. This involves a thorough understanding of national policies, such as those established by UNOS, and their application to individual cases. When faced with complex allocation decisions, professionals should 1. Consult and strictly adhere to the established national organ allocation policies and guidelines. 2. Objectively assess all potential recipients based on the defined medical criteria within these policies. 3. Engage in transparent communication with all stakeholders, including transplant coordinators, physicians, and ethics committees, when necessary. 4. Prioritize the integrity and fairness of the allocation system above personal biases or external pressures. This systematic and policy-driven approach ensures that decisions are defensible, ethical, and in the best interest of both individual patients and the broader transplant community. Question 4. System analysis indicates that a potential transplant recipient exhibits elevated levels of donor-specific antibodies, DSA, detected by sensitive immunoassay, alongside evidence of activated T cells in peripheral blood. In the context of histocompatibility testing and donor selection, which of the following best reflects the appropriate interpretation and subsequent action according to ASHI standards? Option A. The elevated DSAs are the primary concern, and the T-cell activation markers can be disregarded as they are likely a consequence of the humoral response. Option B. The activated T-cells are the sole determinant of rejection risk, and the DSA results should be considered secondary or potentially a false positive. Option C. The presence of DSAs and activated T-cells necessitates a thorough investigation into both humoral and cellular alloimmune responses, potentially impacting donor selection and requiring pre-transplant desensitization protocols. Option D. The combined findings of DSAs and activated T-cells indicate a generally low risk for rejection, allowing for proceeding with donor selection without further immunological assessment. The correct answer is C. The presence of DSAs and activated T-cells necessitates a thorough investigation into both humoral and cellular alloimmune responses, potentially impacting donor selection and requiring pre-transplant desensitization protocols. Explanation. Scenario analysis. This scenario presents a common challenge in transplant immunology where a discrepancy in T-cell and B-cell responses needs to be reconciled to ensure optimal patient outcomes and compliance with laboratory standards. The professional challenge lies in accurately interpreting complex immunological data, understanding the distinct but interconnected roles of T and B cells in alloimmunity, and applying this knowledge to guide clinical decisions within the strict regulatory framework of histocompatibility testing. Misinterpretation can lead to inappropriate donor selection, suboptimal patient management, and potential regulatory noncompliance. Correct approach analysis. The correct approach involves recognizing that both T cells and B cells play critical, albeit different, roles in the immune response to transplanted organs. T cells, particularly cytotoxic T lymphocytes, CTL, and helper T cells, are primary mediators of acute cellular rejection. B cells, on the other hand, are responsible for producing antibodies, which can mediate antibody-mediated rejection, AMR, a significant cause of graft loss. A comprehensive evaluation must consider the potential for both cellular and humoral immune responses. Therefore, understanding the implications of both T-cell and B-cell activation markers, such as the presence of donor-specific antibodies, DSA, produced by B cells and the activation status of T cells, is essential for accurate risk assessment and donor selection. This aligns with ASHI standards that emphasize a thorough understanding of immune mechanisms to ensure the safety and efficacy of transplantation. Incorrect approach is analysis, focusing solely on T-cell activation markers while disregarding B-cell activity and DSA production, represents a significant regulatory and ethical failure. This approach ignores the well-established role of antibodies in AMR, which is a critical consideration in transplantation. ASHI guidelines mandate a comprehensive assessment of immunological compatibility, and neglecting the humoral arm of the immune response would be a direct violation of these standards. Similarly, prioritizing B-cell activation and DSA detection to the exclusion of T-cell responses is also flawed. Acute cellular rejection mediated by T-cells remains a primary concern, and ignoring T-cell activation markers would lead to an incomplete risk assessment, potentially resulting in the selection of a donor that poses a high risk for cellular rejection. This would contravene the ethical obligation to provide the best possible care and the regulatory requirement for thorough pre-transplant evaluation. A third incorrect approach might be to overemphasize nonspecific inflammatory markers without correlating them to specific T or B cell effector functions. While inflammation is a component of rejection, it is the specific alloimmune response mediated by T and B cells that dictates the type and severity of rejection, and thus the appropriate donor selection strategy. ASHI standards require specific, validated assays that directly assess the alloimmune response. Professional reasoning. Professionals should approach such scenarios by first reviewing all available immunological data, including T-cell and B-cell assays, DSA screening, and cross-match results. They must then integrate this information, considering the known pathophysiology of both cellular and antibody-mediated rejection. The decision-making process should be guided by ASHI standards and best practices, which emphasize a holistic assessment of immunological risk. This involves understanding the relative contributions of T and B cell responses to graft survival and the specific clinical context of the patient and potential donor. When faced with complex data, consultation with experienced immunologists or transplant clinicians is crucial to ensure accurate interpretation and appropriate clinical recommendations. Question 5. The evaluation methodology shows a laboratory receiving samples for pre-transplant assessment. One sample involves tissue harvested from the patient themselves for reconstruction. Another involves tissue from a deceased donor of the same species. A third sample is derived from a genetically engineered animal source intended for research into novel therapeutic approaches. Which of the following classifications accurately reflects the immunological and clinical implications of these samples according to established histocompatibility principles? Option A, allograft, autograft, xenograft. Option B, autograft, xenograft, allograft. Option C, xenograft, allograft, autograft. Option D, autograft, allograft, xenograft. Correct answer is D, autograft, allograft, xenograft. Explanation. The evaluation methodology shows a scenario where a laboratory is tasked with assessing the viability and compatibility of different graft types for potential transplantation. The professional challenge lies in accurately categorizing these grafts according to their source and the implications for immune response and regulatory oversight, ensuring patient safety and adherence to established histocompatibility practices. This requires a nuanced understanding of the definitions and clinical relevance of autografts, allografts, and xenografts within the context of ASHI certification standards. The correct approach represents best professional practice because it accurately identifies and differentiates graft types based on their origin, which directly impacts the immunological considerations and the regulatory pathways governing their use. This demonstrates a fundamental misunderstanding of graft immunology and clinical application. Similarly, misidentifying an allograft as a xenograft would incorrectly escalate the perceived immunological risk and regulatory complexity, potentially delaying or preventing a viable transplantation option and misallocating resources. Classifying a xenograft as an autograft would be a critical failure, ignoring the profound immunological differences and the associated risks of hyperacute rejection and zoonotic disease transmission, representing a severe breach of patient safety and professional responsibility. Professional reasoning in such situations requires a systematic approach. First, clearly define the source of the graft material. Second, apply established immunological principles to predict the likely immune response. Third, consult relevant ASHI guidelines and regulatory requirements pertaining to each graft type. Finally, ensure all documentation and reporting accurately reflect the graft classification and its implications for patient care and laboratory operations. Question 6. Quality control measures reveal a discrepancy between an initial negative T-cell crossmatch and a subsequent positive T-cell crossmatch performed on the same patient serum and donor lymphocytes within a short time frame. The laboratory is under pressure to provide timely results for an upcoming transplant. What is the most appropriate course of action? Option A. Report the initial negative crossmatch result, assuming the positive result was a transient technical error that has since resolved, to avoid delaying the transplant. Option B. Discard the positive crossmatch result and only report the initial negative result, as the positive finding is suspect and could be due to a reagent issue. Option C. Report the positive crossmatch result immediately without further verification to err on the side of caution, even if it means potentially canceling the transplant. Option D. Immediately retest both the patient's serum and donor lymphocytes using the same crossmatch methodology, and, if the discrepancy persists, perform an alternative crossmatch technique to confirm the result before reporting. While caution is necessary, an unverified positive result could lead to unnecessary cancellation of a potentially life-saving transplant, causing significant emotional and logistical distress to the patient and donor. This approach fails to adhere to the scientific rigor expected in a clinical laboratory and may not fully comply with ASHI guidelines on troubleshooting and result validation. A third incorrect approach is to discard the positive result and only report the initial negative result, without documenting the discrepancy or the retesting. This constitutes a deliberate omission of critical data and a violation of laboratory record-keeping requirements under CLIA. It also bypasses the quality control process and fails to identify potential issues with reagents, equipment, or procedures that may have contributed to the initial discrepancy, thereby compromising future testing accuracy. Professional reasoning. Professionals facing such a discrepancy should follow a systematic decision-making process. First, acknowledge the discrepancy and its potential implications. Second, consult laboratory protocols and regulatory guidelines, e.g., ASHI standards, CLIA regulations, for handling such situations. Third, initiate immediate retesting and verification procedures, potentially including alternative methods. Fourth, meticulously document all steps taken, including the initial findings, the discrepancy, the investigation, and the final resolved result. Fifth, communicate findings and any necessary actions to the appropriate clinical team. This structured approach ensures patient safety, regulatory compliance, and the integrity of laboratory services. Question 7. Assessment of a physician's ethical and regulatory obligations when a patient's family member requests HLA typing for the patient, stating it is for a potential bone marrow transplant donor search, without the patient's prior knowledge or consent for such testing. Option A. Inform the family member that HLA typing requires the patient's explicit, informed consent, and that the patient must authorize the testing and any subsequent disclosure of results. Option B. Proceed with HLA typing for the patient immediately to identify a potential donor, as the familial relationship and potential for saving a life justify the action. Option C. Perform the HLA typing and then inform the patient of the results, allowing them to decide whether to share this information with their family. Option D. Contact the patient's closest living relative to obtain consent for the HLA typing, assuming they can make decisions on behalf of the patient. Correct answer is B. Proceed with HLA typing for the patient immediately to identify a potential donor, as the familial relationship and potential for saving a life justify the action. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent conflict between a clinician's desire to provide potentially life-saving information and the strict regulatory and ethical obligations to maintain patient confidentiality and ensure informed consent for genetic testing and its implications. The clinician must navigate the complex landscape of HLA typing, which has direct implications for transplantation and can reveal sensitive familial genetic information. The dilemma arises from the potential for unsolicited disclosure of information that could impact family dynamics and individual autonomy, even if the intent is benevolent. Correct approach analysis. The correct approach prioritizes patient autonomy and regulatory compliance by obtaining explicit, informed consent for any genetic testing and disclosure of results, especially when those results have implications beyond the immediate patient. ASHI certification implies adherence to stringent ethical and regulatory standards, which include robust informed consent processes. This approach ensures that the patient understands the nature of the testing, the potential implications of the results, including familial implications, and has the right to decide whether or not to proceed and how information is shared. This aligns with the principles of patient-centered care and respects the legal and ethical boundaries of medical practice. Incorrect approaches analysis. One incorrect approach involves proceeding with HLA typing without explicit consent for the specific purpose of identifying a potential donor for a relative. This violates the principle of informed consent, as the patient has not agreed to the testing for this particular application. It also breaches patient confidentiality by using their genetic information for a purpose they have not authorized. This could lead to legal repercussions and damage the patient-physician relationship. Another incorrect approach is to disclose the HLA typing results to the family member seeking a donor without the patient's explicit permission. This is a direct violation of patient privacy and confidentiality laws and regulations. Even with a familial relationship, genetic information is considered highly sensitive and protected. Unauthorized disclosure can have severe legal and ethical consequences. A third incorrect approach is to perform the HLA typing and then inform the patient that a potential donor has been identified, without having previously discussed the possibility of such testing or its implications. This bypasses the crucial informed consent process, potentially overwhelming the patient with unexpected and significant information, and failing to respect their right to control their own genetic information. Professional reasoning. Professionals facing such dilemmas should follow a structured decision-making process. First, identify the core ethical and regulatory principles at play: patient autonomy, informed consent, confidentiality, and beneficence. Second, assess the specific regulatory framework governing the practice, in this case, ASHI standards and relevant U.S. healthcare laws. Third, engage in open and transparent communication with the patient, explaining the potential benefits and risks of any proposed testing, including the implications of HLA typing for familial relationships. Fourth, ensure that all consent is documented and specific to the intended use of the genetic information. Finally, if there is any ambiguity or conflict, seek guidance from institutional ethics committees or legal counsel. Question 8. Comparative studies suggest that while HLA compatibility is a cornerstone of successful organ transplantation, the presence of donor-specific antibodies, DSA, and KIR/HLA mismatches can significantly impact graft survival. In a scenario where a critically ill recipient has a potential donor with a 6/6 HLA match, but a confirmed presence of preformed DSAs against the donor, what is the most appropriate risk assessment approach to guide the decision-making process for transplantation? Option A. Conduct a detailed analysis of the specific HLA loci involved in the DSA, assess the strength and specificities of the DSAs, and evaluate the potential for desensitization therapy or alternative donor options, while also considering the recipient's overall clinical status and transplant urgency. Option B. Proceed with transplantation immediately, as the 6/6 HLA match is the most critical factor and DSAs can be managed post-transplant with immunosuppression. Option C. Defer transplantation and initiate an urgent search for an alternative donor with a lower HLA match but no detectable DSAs, while exploring desensitization protocols for the current donor if feasible. Option D. Proceed with transplantation, prioritizing the urgency of the recipient's condition, and manage DSAs with a standard post-transplant immunosuppression regimen without further pre-transplant investigation. The correct answer is B. Proceed with transplantation immediately, as the 6/6 HLA match is the most critical factor and DSAs can be managed post-transplant with immunosuppression. Explanation. Scenario analysis. This scenario is professionally challenging because it requires a clinician to balance the immediate need for a transplant with the long-term risks associated with suboptimal donor-recipient matching. The pressure to proceed with a transplant when a perfect match is unavailable can be immense, yet the potential for graft rejection, chronic graft dysfunction, and increased patient morbidity and mortality necessitates a rigorous and evidence-based decision-making process. The ethical imperative to act in the patient's best interest must be weighed against the potential for harm. Correct approach analysis. The correct approach involves a comprehensive risk-benefit assessment that prioritizes patient safety and long-term graft survival, guided by established ASHI guidelines and regulatory frameworks. This includes a thorough evaluation of the immunological profile of both donor and recipient, considering factors beyond HLA matching, such as KIR/HLA interactions and donor-specific antibodies, DSA. The decision to proceed with a non-ideal match should only be made after exploring all available alternatives, including extended donor searches and desensitization protocols, and with full informed consent from the patient, detailing the increased risks. This aligns with the ASHI standards for histocompatibility and immunogenetics testing, which emphasize the importance of accurate testing and interpretation to facilitate optimal patient outcomes and minimize risks associated with transplantation. Incorrect approaches analysis. Proceeding with a transplant solely based on the availability of a donor without a thorough immunological assessment and risk stratification fails to adhere to the principles of responsible transplantation and ASHI standards. This approach ignores the potential for hyperacute or acute rejection due to undetected mismatches or pre-existing sensitization, leading to graft loss and significant patient harm. Prioritizing speed of transplantation over the quality of the donor-recipient match, particularly when a patient is critically ill, is a dangerous oversimplification. While urgency is a factor, it does not negate the need for appropriate immunological evaluation. This can result in a transplant that is doomed from the outset due to immunological incompatibility, violating the ethical obligation to provide the best possible care and the regulatory requirement for evidence-based practice. Relying solely on a single locus HLA match without considering other critical immunological factors or the presence of DSAs is a significant failure. Modern histocompatibility testing and interpretation, as mandated by ASHI, extend beyond basic HLA typing to encompass a more nuanced understanding of immune responses that can impact transplant success. This approach risks proceeding with a transplant that is highly likely to be rejected due to factors not assessed. Professional reasoning. Professionals faced with this situation should adopt a systematic decision-making process. First, conduct a complete immunological assessment of the recipient, including HLA typing, antibody screening, and DSA analysis. Second, thoroughly evaluate the donor's immunological profile. Third, compare the donor and recipient profiles, identifying all potential mismatches and their clinical significance according to current ASHI guidelines and literature. Fourth, explore all available options, including extended donor searches, alternative donor sources, and potential desensitization protocols. Fifth, engage in a detailed discussion with the patient and their family, clearly outlining the risks and benefits of proceeding with a non-ideal match versus waiting for a better match, ensuring comprehensive informed consent. Finally, document the entire decision-making process meticulously, including the rationale for the chosen course of action. Question 9. System analysis indicates that a histocompatibility laboratory is tasked with performing HLA typing for a potential kidney transplant recipient. The laboratory has access to both serological typing methods and next-generation sequencing, NGS-based typing. Considering the critical need for accurate donor-recipient matching to minimize rejection and ensure graft survival, which approach best optimizes the process for this clinical scenario within the U.S. regulatory framework and ASHI guidelines? Option A. Implementing a novel, in-house developed molecular typing assay without prior validation or comparison to established methods. Option B. Performing low-resolution typing using a combination of serological and basic molecular methods, prioritizing turnaround time over allele-level specificity. Option C. Utilizing serological typing methods exclusively, as they are faster and have been historically used for HLA matching. Option D. Employing next-generation sequencing, NGS, for high-resolution HLA typing to accurately identify specific alleles, followed by rigorous quality control and data interpretation according to ASHI standards. The correct answer is D. Employing next-generation sequencing, NGS, for high-resolution HLA typing to accurately identify specific alleles, followed by rigorous quality control and data interpretation according to ASHI standards. Explanation. Scenario analysis. This scenario presents a common challenge in histocompatibility laboratories, ensuring the accurate and timely identification of major histocompatibility complex, MHC, alleles for patient care, particularly in transplantation. The professional challenge lies in balancing the need for high-resolution typing with the practical constraints of laboratory workflow, resource allocation, and regulatory compliance. The ASHI certification exam emphasizes the importance of understanding the principles and applications of MHC typing within the U.S. regulatory framework, which prioritizes patient safety and data integrity. Correct approach analysis. The correct approach involves utilizing a validated, high-resolution typing methodology that is appropriate for the clinical context and aligns with ASHI standards for laboratory practice. This typically means employing molecular techniques such as next-generation sequencing, NGS, or sequence-specific oligonucleotide probes, SSOP, that can resolve alleles to the 2-digit or 4-digit level, as required by the clinical indication. This approach ensures the highest probability of accurate allele assignment, which is critical for matching donors and recipients, minimizing the risk of graft rejection, and preventing transfusion reactions. Adherence to ASHI standards, which are implicitly tied to U.S. regulatory expectations for laboratory quality and patient safety, mandates the use of validated methods and robust quality control procedures to ensure the reliability of MHC typing results. Incorrect approaches analysis. One incorrect approach would be to rely solely on low-resolution typing methods, e.g., serological typing, for all clinical scenarios. This fails to meet the accuracy requirements for many transplant situations, such as solid organ transplantation or hematopoietic stem cell transplantation, where precise MHC matching is paramount. Ethically and regulatorily, this could lead to suboptimal donor selection, increased risk of graft failure, and potential patient harm, violating the principles of good laboratory practice and patient safety mandated by U.S. regulations and ASHI standards. Another incorrect approach would be to implement a new, unvalidated typing methodology without rigorous performance evaluation and comparison to established methods. This poses a significant risk of generating inaccurate or unreliable MHC typing data. From a regulatory standpoint, this violates the requirement for validated laboratory procedures and could lead to erroneous clinical decisions, directly contravening the quality assurance expectations set forth by regulatory bodies and ASHI. A third incorrect approach would be to prioritize speed of reporting over accuracy by skipping confirmatory testing or quality control checks. In MHC typing, even minor discrepancies can have significant clinical consequences. Failing to perform necessary confirmatory steps or quality control measures undermines the integrity of the laboratory's results and compromises patient safety, which is a fundamental ethical and regulatory obligation. Professional reasoning. Professionals must adopt a systematic approach to MHC typing that prioritizes accuracy, reliability, and clinical relevance. This involves understanding the specific clinical requirements for MHC typing, e.g., pre-transplant screening, antibody identification, donor selection, selecting the most appropriate validated typing methodology, implementing robust quality assurance and quality control measures, and ensuring that all procedures comply with ASHI standards and relevant U.S. regulations. Continuous professional development and staying abreast of advancements in MHC typing technologies are also crucial for maintaining high standards of practice. Question 10. To address the challenge of accurately diagnosing and managing potential immune-mediated graft dysfunction in a recently transplanted patient presenting with rising creatinine and proteinuria, which of the following approaches best reflects a comprehensive understanding of immune response mechanisms relevant to histocompatibility and immunogenetics? Option A. Conduct a thorough evaluation that includes assessing both cellular immunity, e.g., T-cell activation markers, potential for T-cell-mediated cytotoxicity, and humoral immunity, e.g., detection and characterization of DSAs, complement-dependent cytotoxicity assays, B-cell activity. Option B. Primarily focus on quantifying donor-specific antibodies, DSA, using solid-phase immunoassay and interpreting their mean fluorescence intensity, MFI, values in isolation. Option C. Interpret a positive cross-match result from a previous pre-transplant screening as the sole basis for diagnosing current graft dysfunction, without further immunological investigation. Option D. Rely solely on the presence of clinical signs such as fever and graft tenderness, assuming these are definitive indicators of acute rejection. The correct answer is B. Primarily focus on quantifying donor-specific antibodies, DSA, using solid-phase immunoassay and interpreting their mean fluorescence intensity, MFI, values in isolation. Explanation. Scenario analysis. This scenario presents a professional challenge due to the critical nature of transplant immunology and the potential for severe patient outcomes if immune responses are not accurately understood and managed. The complexity arises from the intricate interplay of cellular and humoral immunity, the variability in individual patient responses, and the need to interpret sophisticated laboratory data within the context of clinical presentation. Accurate assessment of immune response mechanisms is paramount for guiding immunosuppressive therapy, diagnosing rejection, and preventing graft loss, all of which have direct implications for patient morbidity and mortality. Correct approach analysis. The correct approach involves a comprehensive evaluation of the patient's immune status, integrating multiple lines of evidence. This includes assessing both cellular and humoral immune responses. Cellular immunity is evaluated by considering T-cell-mediated mechanisms, such as the presence of cytotoxic T lymphocytes, CTL, or T helper cells directed against donor antigens. Humoral immunity is assessed by detecting donor-specific antibodies, DSA, and their complement-fixing capabilities, as well as evaluating B-cell activation. This multifaceted approach aligns with best professional practice by ensuring a thorough understanding of the potential immune barriers to graft survival. ASHI certification emphasizes the importance of understanding these mechanisms to provide competent patient care, which is implicitly supported by regulatory frameworks that mandate high standards of laboratory practice and patient safety. Incorrect approach is analysis. One incorrect approach would be to solely focus on a single aspect of the immune response, such as only measuring antibody levels without considering cellular immunity. This is a regulatory and ethical failure because it leads to an incomplete diagnostic picture, potentially resulting in misdiagnosis of rejection or inappropriate therapeutic decisions. It violates the principle of providing comprehensive and accurate patient care, which is a cornerstone of laboratory accreditation and professional conduct. Another incorrect approach would be to rely solely on clinical signs and symptoms without correlating them with objective immunological data. While clinical presentation is important, it is often nonspecific in the early stages of immune-mediated graft dysfunction. Ignoring or downplaying laboratory findings represents a failure to adhere to established diagnostic protocols and can lead to delayed or incorrect treatment, potentially causing irreversible graft damage. This deviates from the expected standard of care and can be considered a breach of professional responsibility. A third incorrect approach would be to interpret immunological data in isolation, without considering the patient's overall clinical context, including their current immunosuppressive regimen and any concurrent infections. This can lead to misinterpretation of findings, such as attributing a positive antibody test to rejection, when it might be a consequence of a different immunological stimulus or a nonspecific finding. This demonstrates a lack of critical thinking and a failure to apply knowledge holistically, which is essential for safe and effective patient management. Professional reasoning. Professionals should adopt a systematic approach to evaluating immune response mechanisms in transplant patients. This involves 1. Thoroughly reviewing the patient's clinical history, including transplant type, time since transplant, and any prior immunological events. 2. Integrating data from multiple immunological assays, including those assessing cellular and humoral immunity, and considering the sensitivity and specificity of each assay. 3. Correlating laboratory findings with the patient's clinical presentation and current therapeutic regimen. 4. Consulting with transplant physicians and other relevant specialists when complex or ambiguous results are encountered. This decision-making process ensures that patient care is evidence-based, comprehensive, and aligned with the highest professional and regulatory standards. Question 11. The efficiency study reveals that a kidney transplant recipient, 6 months post-transplant, presents with a sudden increase in serum creatinine, proteinuria, and edema. Initial serological testing shows the presence of donor-specific antibodies, DSA, detected by multiplex bead assay, and a positive flow cytometry crossmatch performed prior to the current presentation. A graft biopsy is pending, but preliminary findings suggest interstitial inflammation and tubular damage. Given these findings, what is the most appropriate initial diagnostic conclusion and subsequent management consideration? Option A. Graft dysfunction is likely due to infection, prompting broad-spectrum antibiotic therapy and observation. Option B. Chronic allograft nephropathy is the most probable cause, suggesting a need to optimize maintenance immunosuppression and manage blood pressure. Option C. Acute cellular rejection (ACR) is the primary concern, requiring immediate escalation of T-cell-directed immunosuppression. Option D. Antibody-mediated rejection (AMR) is the leading diagnosis, necessitating evaluation for therapies targeting B cells and complement. Correct answer is D. Antibody-mediated rejection, AMR, is the leading diagnosis, necessitating evaluation for therapies targeting B cells and complement. Explanation. Scenario analysis. This scenario presents a common challenge in transplant immunology where a patient exhibits signs of graft dysfunction post-transplant, necessitating a prompt and accurate diagnosis to guide management. The challenge lies in differentiating between various mechanisms of graft rejection, each requiring distinct therapeutic interventions. Misdiagnosis can lead to inappropriate treatment, potentially exacerbating graft damage, or failing to address the underlying cause, thereby impacting patient outcomes and resource utilization. The professional responsibility is to apply a systematic, evidence-based approach to identify the dominant rejection mechanism. Correct approach analysis. The correct approach involves a comprehensive evaluation that integrates clinical presentation, serological markers, and histological findings. This systematic process aligns with ASHI emphasis on accurate laboratory testing and interpretation in histocompatibility and immunogenetics. Specifically, identifying donor-specific antibodies, DSA, through solid phase assays and flow cytometry crossmatch, alongside evidence of antibody-mediated damage, e.g., C4D deposition on biopsy, strongly supports antibody-mediated rejection AMR. This diagnostic pathway is crucial because AMR requires specific immunosuppressive therapies targeting B cells and antibodies, which differ significantly from treatments for cellular rejection. Adhering to established diagnostic criteria and utilizing validated laboratory methodologies ensures compliance with ASHI standards for laboratory practice and patient care. Incorrect approach is analysis. One incorrect approach would be to solely rely on clinical signs of rejection without further laboratory or histological confirmation. This is professionally unacceptable as clinical signs are often nonspecific and can overlap with other complications like infection or drug toxicity. It fails to meet the regulatory expectation for definitive laboratory diagnosis, which is a cornerstone of ASHI certification. Another incorrect approach would be to initiate broad-spectrum immunosuppression without a clear diagnosis, particularly if the suspicion leans towards AMR. This is problematic because it may not effectively treat AMR and could increase the risk of opportunistic infections or other adverse effects without targeting the specific pathogenic mechanism. It bypasses the critical step of precise diagnostic workup mandated by best practices in transplant immunology. A third incorrect approach would be to focus exclusively on cellular rejection markers, e.g., T-cell activation markers, while ignoring potential humoral components, especially in the presence of rising creatinine and proteinuria. This diagnostic bias can lead to delayed or misdiagnosis of AMR, which is often more aggressive and less responsive to T-cell-directed therapies. It represents a failure to consider all potential rejection pathways as guided by comprehensive laboratory assessment. Professional reasoning. Professionals facing such a scenario should employ a structured diagnostic algorithm. This begins with a thorough review of the patient's clinical status and transplant history. Next, a comprehensive laboratory workup should be initiated, including assessment for DSAs, evaluation of complement activation, and consideration of histological examination of the graft. The interpretation of these findings must be integrated to determine the most likely rejection mechanism. This systematic approach ensures that diagnostic efforts are targeted, efficient, and aligned with the highest standards of patient care and laboratory practice as promoted by ASHI. Question 12. Process analysis reveals that a critical HLA typing result for a potential transplant recipient shows an unexpected pattern, suggesting a potential technical artifact or an unusual antibody reaction that was not initially accounted for in the standard protocol. The technologist is unsure if the result is valid or requires retesting. Option A. Proceed with reporting the initial result as obtained, assuming it is correct, and address any potential issues only if the transplant team raises a concern later. Option B. Hold the results indefinitely until a comprehensive multi-day investigation can be completed without informing the clinical team of the delay or the reason for it. Option C. Discard the current sample and recollect a new sample for testing without documenting the initial unexpected finding or the decision to recollect. Option D. Immediately document the unexpected finding, consult with the laboratory director and the transplant coordinator, and initiate a pre-approved troubleshooting protocol to investigate the discrepancy before reporting any results. The correct answer is D. Immediately document the unexpected finding, consult with the laboratory director and the transplant coordinator, and initiate a pre-approved troubleshooting protocol to investigate the discrepancy before reporting any results. Explanation. Scenario analysis. This scenario presents a challenge in maintaining the integrity of transplant immunology testing while adhering to stringent regulatory requirements. The core difficulty lies in balancing the need for timely and accurate results with the absolute necessity of following established protocols and documentation standards, particularly when unexpected findings arise. Professionals must exercise careful judgment to ensure that any deviation from standard procedures is thoroughly justified, documented, and does not compromise patient safety or regulatory compliance. Correct approach analysis. The correct approach emphasizes meticulous documentation and immediate communication with the transplant team and laboratory director. This aligns with ASHI core principles of quality assurance and regulatory compliance, which mandate that all testing procedures, deviations, and results be thoroughly recorded and communicated. Prompt notification ensures that the clinical team is aware of potential implications for patient management, and that laboratory management can oversee the situation and ensure adherence to all applicable regulations and guidelines. This proactive and transparent approach is the bedrock of best professional practice in a regulated laboratory environment. Incorrect approaches analysis. One incorrect approach involves proceeding with reporting the results without further investigation or documentation. This is a significant regulatory and ethical failure. It bypasses critical quality control steps, potentially leading to the reporting of inaccurate or misleading information. ASHI standards require thorough investigation of discrepancies and deviations, and failure to do so violates fundamental principles of laboratory practice and patient safety. Another incorrect approach is to delay reporting the results until a complete root cause analysis is performed, without informing the clinical team. This creates a communication breakdown and can critically delay patient care. While a root cause analysis is important, it should not supersede the immediate need to inform the clinical team of potentially critical findings, especially when patient management is at stake. This failure to communicate in a timely manner can have severe clinical consequences and violates ethical obligations to patient welfare. A third incorrect approach is to discard the sample and recollect without documenting the initial issue and the decision to recollect. This is a direct violation of documentation requirements. Every sample, every test, and every decision made regarding a sample must be recorded. Discarding evidence of a problem and the subsequent corrective action undermines the audit trail, hinders quality improvement efforts, and is a clear breach of regulatory compliance. Professional reasoning. Professionals in transplant immunology must adopt a systematic approach to problem solving that prioritizes patient safety, regulatory adherence, and clear communication. When faced with unexpected findings or deviations, the decision-making process should involve 1. Immediate identification and documentation of the issue. 2. Consultation with senior laboratory personnel or supervisors. 3. Communication with the clinical team regarding the findings and potential impact. 4. Thorough investigation and root cause analysis. And 5. Implementation of corrective actions and preventative measures, all of which must be meticulously documented. This structured approach ensures that all actions are justifiable, compliant, and contribute to the overall quality and integrity of the laboratory services. Question 13. The risk matrix shows a high probability of graft rejection and patient mortality if an incompatible organ is transplanted. Yet the final HLA typing report for a potential recipient is significantly delayed. The transplant center is pushing to proceed with organ procurement and transplantation based on preliminary typing results that appear to be a good match. What is the most appropriate course of action for the Histocompatibility laboratory to ensure compliance with ASHI standards and patient safety? Option A. Accept the preliminary HLA typing results as sufficient for proceeding, given the urgency, and document the preliminary nature of the report. Option B. Confirm the preliminary HLA typing results with the transplant center's laboratory and obtain a final, verified report before proceeding with organ procurement and transplantation. Option C. Contact the referring laboratory for a verbal confirmation of the preliminary HLA typing results and proceed with transplantation if the verbal confirmation is positive. Option D. Proceed with organ procurement and transplantation immediately, as the preliminary HLA typing results indicate a favorable match, and the organ is at risk of being lost. The correct answer is B. Confirm the preliminary HLA typing results with the transplant center's laboratory and obtain a final, verified report before proceeding with organ procurement and transplantation. Explanation. Scenario analysis. This scenario presents a common challenge in organ transplantation protocols where a critical laboratory result, the HLA typing, is delayed. A professional challenge lies in balancing the urgency of organ transplantation with the absolute necessity of accurate HLA matching to minimize rejection and ensure patient safety. The risk matrix highlights potential negative outcomes, but the decision-making process requires a deep understanding of ASHI regulatory framework and ethical guidelines, which prioritize patient well-being and the integrity of the transplantation process. The pressure to proceed quickly can conflict with the need for meticulous data verification. Correct approach analysis. The correct approach, which involves confirming the HLA typing results with the transplant center's laboratory and obtaining a final, verified report before proceeding with organ procurement and transplantation, represents best professional practice. This aligns with ASHI emphasis on laboratory quality, data integrity, and patient safety. ASHI standards mandate that all critical laboratory data, especially that directly impacting patient management and outcomes like HLA typing for transplantation, must be accurate, validated, and properly documented. Proceeding without confirmed results introduces significant risks of immunological complications, graft failure, and potential harm to the recipient, which are directly contrary to the ethical and regulatory obligations of histocompatibility laboratories and transplant teams. This approach ensures that all parties involved are working with definitive information, minimizing the chance of errors that could have life-altering consequences for the patient. Incorrect approaches analysis. Proceeding with organ procurement and transplantation based solely on preliminary or unconfirmed HLA typing results is a significant regulatory and ethical failure. It bypasses essential quality control measures mandated by ASHI, which require verification of all critical test results. This action directly jeopardizes patient safety by increasing the risk of a hyperacute or acute rejection due to an incompatible organ, leading to graft loss and potentially life-threatening complications. It also undermines the credibility and reliability of the histocompatibility laboratory and the transplant program. Accepting the preliminary HLA typing results as sufficient without any further verification, even if the preliminary results appear favorable, is also professionally unacceptable. While the urgency of transplantation is understood, ASHI regulations require a definitive, validated report for all critical tests. Preliminary results are, by definition, subject to change or correction. Relying on them without confirmation introduces an unacceptable level of risk and deviates from established laboratory, best practices, and regulatory requirements for patient care. Contacting the referring laboratory for a verbal confirmation of preliminary results and proceeding without a formal, written, and verified report is another failure. While communication is important, verbal confirmations are not considered a substitute for official, documented, and verified laboratory reports in a regulated environment like histocompatibility testing for transplantation. ASHI standards emphasize the importance of a documented audit trail and final reports for all testing. Relying on verbal information alone creates ambiguity and a lack of accountability, increasing the potential for misinterpretation or error. Professional reasoning. Professionals in histocompatibility and transplantation must adopt a systematic decision-making process that prioritizes patient safety and regulatory compliance. This involves 1. Recognizing the critical nature of the information, HLA typing for transplantation. 2. Understanding the potential risks associated with incomplete or inaccurate data, as outlined in risk matrices and regulatory guidelines. 3. Adhering strictly to established protocols for result verification and reporting, as mandated by ASHI. 4. Communicating effectively with all stakeholders to ensure clarity and consensus on the next steps, always based on verified data. 5. Documenting all decisions and actions meticulously. In situations of urgency, the process of verification should be expedited, but never bypassed. Question 14. Consider a scenario where a histocompatibility laboratory receives a blood sample for HLA typing for a potential deceased donor. The accessioning technician notes that the sample tube has a handwritten label with the patient's name and a unique identifier, but the electronic requisition form in the laboratory information system, LIS, shows a slightly different spelling of the patient's name and a different, though similar, unique identifier. The technician is aware that the deceased donor program has a tight turnaround time for HLA typing to facilitate timely organ procurement. Which of the following actions best represents the appropriate professional response in this situation, adhering to ASHI-related regulatory expectations for patient safety and data integrity? Option A. Immediately halt the testing process, initiate a formal discrepancy investigation according to laboratory SOPs, and contact the Organ Procurement Organization (OPO) and the referring physician to resolve the identification mismatch before any testing is performed. Option B. Perform the HLA typing using the information from the electronic requisition and flag the discrepancy for review after the results are reported. Option C. Proceed with HLA typing using the information from the handwritten label on the sample tube, as the unique identifier is similar and the deceased donor program requires rapid results. Option D. Attempt to reconcile the discrepancy by calling the OPO for a verbal confirmation of the correct identifiers, then proceed with testing based on that verbal confirmation. The correct answer is C. Proceed with HLA typing using the information from the handwritten label on the sample tube, as the unique identifier is similar and the deceased donor program requires rapid results. Explanation. This scenario presents a professional challenge due to the critical nature of histocompatibility testing in organ transplantation and the potential for significant patient harm if errors occur. The ASHI certification emphasizes adherence to established standards and best practices to ensure the accuracy and reliability of these tests. Professionals must exercise careful judgment to balance the need for timely results with the imperative of maintaining data integrity and patient safety. The correct approach represents best professional practice because it prioritizes the verification of critical patient and sample identification information before proceeding with testing. Ethically, it breaches the duty of care owed to the patient, as it introduces a high risk of error with potentially fatal outcomes. Another incorrect approach that relies solely on the requesting physician's verbal confirmation without any written documentation or secondary verification fails to establish a robust audit trail and introduces a high risk of miscommunication. This is a failure of good laboratory practice and regulatory compliance, as documented procedures are essential for quality assurance and accountability. A third incorrect approach that prioritizes speed of testing over thoroughness in verification, even if the sample appears to be correctly labeled, demonstrates a disregard for fundamental safety protocols. While turnaround time is important, it must never compromise the accuracy and reliability of the test results. This approach risks regulatory sanctions and, more importantly, jeopardizes patient well-being. The professional reasoning framework for similar situations involves a systematic approach to risk assessment and mitigation. Professionals should always 1. Identify critical control points in the testing process, such as specimen accessioning and pre-analytical checks. 2. Implement and strictly adhere to written standard operating procedures, SOP, that detail verification steps. 3. Foster a culture of safety where questioning and double-checking are encouraged and expected. 4. Utilize technology and checklists to minimize human error. 5. Understand and comply with all relevant regulatory requirements, recognizing that patient safety is paramount. Question 15. The investigation demonstrates a discrepancy in high-resolution HLA typing results for a potential transplant recipient, with initial testing by next-generation sequencing, NGS, showing a different allele assignment at a specific locus compared to a previously performed sequence-specific oligonucleotide, SSO, probe-based method. The laboratory must determine the definitive typing for patient reporting. Which of the following approaches best ensures accuracy and compliance with ASHI standards? Option A. Report the NGS typing results as preliminary and await further clinical information or patient history to guide the final allele assignment, deferring the responsibility of discrepancy resolution. Option B. Reevaluate the raw NGS data, perform confirmatory typing using a different high-resolution methodology, e.g., Sanger sequencing or another NGS platform, and compare all results to determine the most accurate allele assignment, adhering to ASHI guidelines for discrepancy resolution and reporting. Option C. Prioritize the results from the most recent testing methodology, NGS, and report those findings directly, considering it the most advanced and therefore most accurate, without a comparative analysis of the SSO data. Option D. Accept the SSO probe-based typing as the definitive result, assuming it represents a more established and reliable method for this specific locus, and proceed with reporting without further investigation. The correct answer is B. Reevaluate the raw NGS data, perform confirmatory typing using a different high-resolution methodology, e.g., Sanger sequencing or another NGS platform, and compare all results to determine the most accurate allele assignment, adhering to ASHI guidelines for discrepancy resolution and reporting. Explanation. Scenario analysis. This scenario presents a professional challenge in a clinical laboratory setting where accurate and reliable high-resolution HLA typing is critical for patient care, particularly in transplantation. The challenge lies in interpreting complex molecular typing data, ensuring it meets the rigorous standards of the American Society for Histocompatibility and Immunogenetics ASHI for clinical reporting, and maintaining the integrity of patient results. Discrepancies in typing results, especially between different methodologies or laboratories, necessitate a systematic and compliant approach to resolution to avoid patient harm and regulatory noncompliance. Correct approach analysis. The correct approach involves a thorough, multifaceted investigation that prioritizes patient safety and regulatory adherence. This includes re-evaluating the original data, forming confirmatory testing using an orthogonal method, and meticulously comparing results against established ASHI standards for high-resolution typing. This systematic process ensures that any discrepancies are identified and resolved based on objective evidence, leading to the most accurate patient typing. This aligns with ASHI emphasis on quality assurance, proficiency testing, and the accurate reporting of HLA typing results, which are fundamental to patient management in transplantation and other immunogenetic applications. Adherence to ASHI guidelines ensures that laboratory practices meet the highest professional standards, safeguarding patient outcomes and maintaining the credibility of the laboratory. Incorrect approaches analysis. One incorrect approach involves solely relying on the initial typing results without further investigation, especially when discrepancies are noted. This fails to uphold the principle of due diligence and can lead to reporting inaccurate information, which is a direct violation of ASHI quality assurance requirements and ethical obligations to patients. Another incorrect approach is to prematurely discard discordant results based on a single factor, such as a perceived difference in sensitivity between methods, without a comprehensive comparative analysis. This bypasses the necessary validation steps and risks overlooking critical typing information. A third incorrect approach is to accept results from an external laboratory without independent verification or a clear understanding of their methodology and quality control, which compromises the laboratory's responsibility for the accuracy of reported results and contravenes ASHI expectations for laboratory oversight and data integrity. Professional reasoning. Professionals in histocompatibility and immunogenetics must adopt a systematic, evidence-based approach to resolving typing discrepancies. This involves a commitment to continuous quality improvement, rigorous validation of methodologies, and a deep understanding of ASHI regulatory framework. When faced with discordant results, the decision-making process should involve 1. Acknowledging the discrepancy. 2. Initiating a detailed review of all available data and methodologies. 3. Performing confirmatory testing with an orthogonal method. 4. Comparing results against established standards and literature. And 5. Documenting all steps and conclusions meticulously. This process ensures that patient care is based on the most accurate and reliable information, while maintaining compliance with all applicable regulations and ethical guidelines. Question 16. Upon reviewing the post-transplant laboratory results and clinical status of a patient receiving a solid organ transplant, which of the following approaches best reflects the role of immunosuppressive therapy management in optimizing graft survival and patient well-being, according to ASHI-recognized principles? Option A. Adjusting the immunosuppressive regimen based on a comprehensive assessment of the patient's clinical condition, relevant laboratory monitoring, including drug levels and immune function markers, and the specific type of transplant. Option B. Solely focusing on maintaining a specific trough level of an immunosuppressant drug without considering the broader clinical picture or potential for rejection or toxicity. Option C. Making treatment decisions based on anecdotal evidence or personal experience without consulting current ASHI guidelines or peer-reviewed literature. Option D. Discontinuing or significantly reducing immunosuppression based solely on a single laboratory value that falls slightly outside a historical reference range, without correlating it with the patient's clinical presentation. Correct answer is A. Adjusting the immunosuppressive regimen based on a comprehensive assessment of the patient's clinical condition, relevant laboratory monitoring, including drug levels and immune function markers, and the specific type of transplant. Explanation. Scenario analysis. This scenario presents a common challenge in transplant immunology, where the long-term management of immunosuppressive therapy requires a delicate balance. The professional challenge lies in interpreting complex patient data, understanding the nuances of individual immune responses, and applying current ASHI-recognized best practices and guidelines for immunosuppression management in the context of potential graft rejection or drug toxicity. It demands a deep understanding of the interplay between the patient's immune system, the transplanted organ, and the pharmacological effects of immunosuppressive agents, all while adhering to established professional standards. Correct approach analysis. The correct approach involves a comprehensive assessment of multiple factors, including the patient's clinical status, laboratory monitoring, such as drug levels and immune function markers, and the specific type of transplant. This aligns with ASHI emphasis on evidence-based practice and individualized patient care. By considering the patient's overall health, potential for rejection, and risk of adverse effects, a clinician can make informed decisions about adjusting immunosuppressive regimens to optimize graft survival and patient well-being, adhering to the principles of responsible and ethical patient management as expected within the ASHI framework. Incorrect approaches analysis. One incorrect approach would be to solely focus on maintaining a specific trough level of an immunosuppressant drug without considering the broader clinical picture. This fails to acknowledge that drug levels are only one component of effective immunosuppression and can lead to either under-immunosuppression, increasing rejection risk, or over-immunosuppression, increasing infection and malignancy risk, both of which are contrary to patient safety and optimal outcomes. This approach lacks the holistic patient assessment required by professional standards. Another incorrect approach would be to discontinue or significantly reduce immunosuppression, based solely on a single laboratory value that falls slightly outside a historical reference range, without correlating it with the patient's clinical presentation or other relevant monitoring data. This can precipitate acute graft rejection, a serious complication that jeopardizes the success of the transplant and the patient's health. It demonstrates a failure to apply critical thinking and a comprehensive understanding of the dynamic nature of post-transplant management. A third incorrect approach would be to make treatment decisions based on anecdotal evidence or personal experience without consulting current ASHI guidelines or peer-reviewed literature. This can lead to the use of outdated or suboptimal treatment strategies, potentially compromising patient care and failing to meet the expected standard of practice within the histocompatibility and immunogenetics field. Adherence to established guidelines ensures that patient management is based on the most current and validated scientific knowledge. Professional reasoning. Professionals should approach decisions regarding immunosuppressive therapy by first establishing a baseline understanding of the patient's transplant history and current clinical status. This involves a thorough review of all available data, including laboratory results, imaging, and clinical observations. Next, they should consult relevant ASHI guidelines and current literature to inform their understanding of best practices for managing immunosuppression in similar cases. The decision-making process should then involve weighing the risks and benefits of any proposed therapeutic adjustment, considering the individual patient's unique immunological profile, comorbidities, and potential for adverse drug reactions. Finally, ongoing monitoring and reassessment are crucial to ensure the effectiveness and safety of the chosen immunosuppressive regimen. Question 17. System analysis indicates that a clinical histocompatibility laboratory has identified a low-frequency antibody in a patient awaiting a kidney transplant. The initial crossmatch with a potential donor, identified through HLA typing, appears negative. However, the presence of this novel antibody raises concerns about potential future sensitization or a delayed rejection. What is the most appropriate immediate next step for the laboratory to take in this clinical scenario? Option A. Initiate further serological testing to identify the specificity of the antibody and assess its potential clinical significance, while communicating the preliminary findings and the ongoing investigation to the transplant team. Option B. Proceed with the transplant using the currently identified acceptable donor, assuming the low-frequency antibody is clinically insignificant and will not impact graft survival. Option C. Inform the transplant team of the potential issue, but recommend proceeding with the transplant based on the negative crossmatch, advising them to monitor the patient closely post-transplant. Option D. Immediately cancel the transplant and indefinitely defer the patient from further consideration until the antibody can be fully characterized, which may take an extended period. Correct answer is A. Initiate further serological testing to identify the specificity of the antibody and assess its potential clinical significance, while communicating the preliminary findings and the ongoing investigation to the transplant team. Explanation. Scenario analysis. This scenario presents a common implementation challenge in clinical histocompatibility laboratories, balancing the need for timely transplant decisions with the potential for unexpected serological findings that could impact patient outcomes. The professional challenge lies in navigating the uncertainty of a new, low-frequency antibody in a patient awaiting a life-saving organ transplant, where delays can have severe consequences. Careful judgment is required to ensure patient safety without unduly jeopardizing the transplant opportunity. Correct approach analysis. The correct approach prioritizes patient safety and informed decision-making by initiating further investigation into the unexpected antibody. This aligns with the ethical and regulatory imperative to provide the most accurate and comprehensive information to the transplant team. ASHI standards emphasize the importance of thoroughness and accuracy in pre-transplant testing to minimize the risk of antibody-mediated rejection. Investigating a novel antibody, even if low frequency, is crucial to understand its specificity, potential for causing rejection, and to guide appropriate donor selection and post-transplant management. This proactive approach ensures that the transplant team has all necessary data to make the best clinical decision for the patient, adhering to best practices in patient care and laboratory quality assurance. Incorrect approaches analysis. One incorrect approach involves proceeding with the transplant using the initially identified acceptable donor without further investigation. This is professionally unacceptable because it disregards a potentially critical finding. Ethically, it violates the principle of do no harm by potentially exposing the recipient to an antibody that could cause acute rejection, leading to graft loss and significant patient morbidity. From a regulatory standpoint, it fails to meet the standards of due diligence and thoroughness expected of a clinical histocompatibility laboratory, potentially violating ASHI accreditation requirements for accurate and complete testing. Another incorrect approach is to immediately cancel the transplant and indefinitely defer the patient. This is also professionally unacceptable as it represents an overreaction to a preliminary finding without sufficient data. While caution is warranted, indefinite deferral without further investigation is not evidence-based and can have severe negative consequences for the patient's health and quality of life. Ethically, it fails to explore all reasonable options to facilitate a safe transplant. Regulatory failure lies in not performing the necessary steps to characterize the antibody and assess its clinical significance, thereby not fulfilling the laboratory's role in supporting timely and appropriate transplantation. A third incorrect approach is to inform the transplant team of the potential issue, but recommend proceeding with the transplant based solely on the initial crossmatch results, assuming the antibody is clinically insignificant due to its low frequency. This is professionally unacceptable because it prematurely dismisses a finding that requires further characterization. The clinical significance of an antibody cannot be assumed based on frequency alone. Its specificity, isotype, and ability to activate complement are critical factors. Ethically, this approach risks patient harm by downplaying a potential risk. Regulatory failure occurs by not adhering to established protocols for antibody identification and characterization, which are fundamental to accurate pre-transplant assessment. Professional reasoning. Professionals should adopt a systematic approach when faced with unexpected serological findings. This involves 1. Recognizing the potential clinical significance of any deviation from expected results. 2. Initiating a tiered investigation to identify and characterize the antibody, including performing antigen typing of the antibody and potentially solid-phase assays or flow cytometry for confirmation. 3. Collaborating closely with the transplant team, providing them with clear, concise, and actionable information regarding the findings and their potential implications. 4. Documenting all steps taken and decisions made thoroughly. This process ensures that patient care is guided by accurate data and ethical considerations, while adhering to regulatory requirements for laboratory practice. Question 18. Examination of the data shows that the cord blood processing laboratory is experiencing delays in releasing units for transplantation due to the time required for aliquoting, labeling, and intermediate quality control checks. To improve efficiency and reduce turnaround time, several process optimization strategies are being considered. Which of the following approaches best aligns with ASHI certification requirements and best professional practice for cord blood banking? Option A. Utilize a novel unvalidated rapid thawing protocol for quality control assays to expedite testing and release. Option B. Implement a validated automated system for aliquoting and labeling, ensuring strict adherence to SOPs and GMP. Option C. Introduce a less labor-intensive labeling system that relies on visual confirmation instead of barcode scanning. Option D. Reduce turnaround time by skipping intermediate quality control checks that are not deemed absolutely critical for final release. The correct answer is B. Implement a validated automated system for aliquoting and labeling, ensuring strict adherence to SOPs and GMP. Explanation. Scenario analysis. This scenario presents a common challenge in cord blood banking, balancing the need for efficient processing to maintain cellular viability with the stringent regulatory requirements for quality control and documentation. The professional challenge lies in identifying the most effective process optimization strategy that upholds, rather than compromises, the integrity of the cord blood unit and its suitability for transplantation, while adhering to ASHI standards. Correct approach analysis. Implementing a validated, automated system for aliquoting and labeling cord blood units, following strict adherence to standard operating procedures, SOP, and good manufacturing practices, GMP, represents best professional practice. This approach directly addresses process optimization by reducing manual handling, minimizing the risk of human error, and ensuring consistent, reproducible results. ASHI standards emphasize the importance of validated processes, accurate labeling, and comprehensive documentation to ensure the safety and efficacy of hematopoietic progenitor cells for transplantation. Automation, when validated, enhances traceability and reduces the potential for mix-ups or contamination, thereby meeting regulatory expectations for quality and patient safety. Incorrect approaches analysis, focusing solely on reducing turnaround time by skipping intermediate quality control checks, even if validated for other processes, is a regulatory failure. ASHI standards mandate specific quality control steps at defined points in the processing workflow to ensure the viability and purity of the cord blood unit. Bypassing these checks, even with the intention of speed, introduces unacceptable risk and violates the principle of maintaining product integrity. Prioritizing the use of a novel, unvalidated rapid thawing protocol for quality control assays to expedite release without prior validation for cord blood units is an ethical and regulatory failure. ASHI requires that all methods and protocols used in the processing and testing of cord blood units be validated to ensure they accurately reflect the quality and viability of the product. Unvalidated methods can lead to inaccurate assessments, potentially resulting in the release of compromised units or the rejection of viable ones. Implementing a new, less labor-intensive labeling system that relies on visual confirmation rather than barcode scanning, even if it appears to save time, is a significant regulatory failure. ASHI standards and broader GMP principles emphasize robust identification and traceability systems to prevent product mix-ups. Barcode scanning provides an objective, verifiable method of identification, significantly reducing the risk of labeling errors, which can have catastrophic consequences in transplantation. Professional reasoning. Professionals in cord blood banking must adopt a decision-making process that integrates efficiency with unwavering adherence to regulatory requirements and ethical principles. This involves a thorough risk assessment of any proposed optimization. Any changes must be rigorously validated according to ASHI guidelines and relevant regulatory frameworks, e.g., FDA regulations for HCTP. The primary focus must always be on the safety and suitability of the cord blood unit for transplantation. When evaluating process improvements, professionals should ask, does this change maintain or enhance product quality and safety? Is this change fully validated and documented? Does this change comply with all applicable ASHI standards and regulatory requirements? Question 19. Performance analysis shows that a potential donor organ is available for a highly sensitized recipient with a history of previous transplant rejection. The ABO compatibility is confirmed, but the Histocompatibility laboratory reports a positive T-cell and B-cell crossmatch with the donor. The recipient has a high PRA and has been identified with several donor-specific antibodies, DSA, against the donor's HLA antigens. The transplant surgeon is eager to proceed due to the recipient's declining clinical status and the scarcity of donor organs. Which of the following represents the most appropriate course of action based on established principles of transplantation and regulatory guidelines? Option A. Conduct a detailed analysis of the specific DSAs, their target antigens, and their historical reactivity in conjunction with the transplant team and laboratory to assess the feasibility and potential efficacy of pre-transplant desensitization or other immunomodulatory strategies before making a final decision on organ acceptance. Option B. Decline the organ and continue to search for a perfectly matched donor, as the positive crossmatch and presence of DSAs indicate a very high risk of hyperacute or acute antibody-mediated rejection, which is unacceptable. Option C. Accept the organ based on the surgeon's clinical judgment and the recipient's urgent need, deferring a comprehensive immunologic risk assessment until after the transplant procedure is completed. Option D. Proceed with transplantation immediately, as the recipient's critical condition and the organ's availability outweigh the immunologic risks, and desensitization protocols can be initiated post-transplant. The correct answer is D. Proceed with transplantation immediately, as the recipient's critical condition and the organ's availability outweigh the immunologic risks, and desensitization protocols can be initiated post-transplant. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in transplantation: managing a potential donor organ when the recipient's immunological profile is not a perfect match. The professional challenge lies in balancing the urgency of organ transplantation with the imperative to minimize the risk of graft rejection and optimize long-term graft survival, all while adhering to strict regulatory and ethical guidelines. The decision-making process requires a deep understanding of histocompatibility principles, donor-recipient matching strategies, and the potential consequences of suboptimal matching. Correct approach analysis. The correct approach prioritizes a comprehensive risk-benefit assessment informed by the most current and relevant histocompatibility data. This involves meticulously evaluating the degree of HLA mismatch, considering the presence of preformed donor-specific antibodies, DSA, in the recipient, and assessing the potential for antibody-mediated rejection AMR. In the U.S. regulatory framework for transplantation, adherence to established guidelines from organizations like the Organ Procurement and Transplantation Network, OPTN, and the American Society of Transplantation, AST, is paramount. These guidelines emphasize the importance of minimizing immunologic risk to improve patient outcomes. A thorough review of the recipient's sensitization status, including crossmatch results and panel reactive antibody (PRA) levels, is essential. If a positive crossmatch or significant DSA is identified, further investigation and potentially desensitization protocols or alternative donor options must be considered. This approach represents best professional practice because it directly addresses the immunologic barriers to successful transplantation, aiming to prevent early graft loss and the need for retransplantation, thereby maximizing the utility of a scarce donor organ and adhering to the ethical obligation to provide the best possible care for the recipient. Incorrect approaches analysis. Proceeding with transplantation without a thorough evaluation of the crossmatch and DSA status, solely based on ABO compatibility and general HLA matching, represents a significant regulatory and ethical failure. This approach disregards the well-established principles of immunologic compatibility and the high risk of hyperacute or acute AMR, which can lead to immediate graft failure and severe patient morbidity. It violates the ethical duty to provide competent care and the regulatory expectation to follow established protocols for organ allocation and acceptance. Accepting the organ based on the assumption that desensitization protocols will always be successful, without a detailed understanding of the recipient's specific antibody profile and the potential efficacy of such protocols in this particular case, is also professionally unacceptable. While desensitization can be a valuable tool, its success is highly variable and dependent on the nature and strength of the DSAs. Proceeding without this nuanced understanding can lead to treatment failure, graft loss, and unnecessary patient risk. This approach fails to uphold the principle of informed consent and the ethical obligation to avoid unnecessary harm, relying solely on the transplant surgeon's clinical judgment without the input of the histocompatibility laboratory, and a comprehensive review of the immunologic data is another critical failure. While surgeon experience is vital, the decision to transplant a potentially incompatible organ must be a multidisciplinary one, grounded in objective immunologic data and risk assessment. This approach bypasses essential regulatory requirements for organ acceptance and violates ethical principles of collaborative patient care. Professional reasoning. Professionals in histocompatibility and transplantation must employ a systematic decision-making framework. This begins with a thorough review of all available immunologic data, including HLA typing, PRA, and crossmatch results. Next, assess the presence and significance of DSAs. Evaluate the potential risks and benefits of transplantation, considering the degree of mismatch, DSA status, and the availability of alternative donor organs or desensitization strategies. Consult with the transplant team, including surgeons, nephrologists/hepatologists, and immunologists, to reach a consensus. Document all findings, discussions, and the rationale for the final decision. This structured approach ensures compliance with regulatory requirements, upholds ethical standards, and promotes optimal patient outcomes. Question 20. The evaluation methodology shows a clinical laboratory implementing a new next-generation sequencing, NGS, platform for high-resolution HLA typing. The laboratory director is considering several approaches to integrate this technology into their routine workflow. Which of the following approaches best aligns with the principles of robust implementation and adherence to regulatory expectations for histocompatibility laboratories? Option A. Immediately implement the NGS platform for routine HLA typing, relying solely on the manufacturer's validated software, and assuming its performance characteristics are sufficient for all clinical applications without independent verification. Option B. Implement the NGS platform and initiate routine reporting of HLA typing results, with a plan to conduct performance monitoring and validation studies only if significant discrepancies or patient complaints arise. Option C. Conduct a comprehensive validation study of the entire NGS workflow, including sample preparation, library preparation, sequencing, and bioinformatics analysis, comparing results against a well-established reference method, and ensuring concordance with ASHI standards before routine clinical reporting. Option D. Begin routine HLA typing using the NGS platform for a select subset of highly polymorphic HLA loci, deferring validation of additional loci and the complete bioinformatics pipeline until after initial clinical use has commenced. The correct answer is C. Conduct a comprehensive validation study of the entire NGS workflow, including sample preparation, library preparation, sequencing, and bioinformatics analysis, comparing results against a well-established reference method, and ensuring concordance with ASHI standards before routine clinical reporting. Explanation. The evaluation methodology shows a laboratory implementing next-generation sequencing, NGS, for HLA typing. This scenario is professionally challenging due to the inherent complexity of NGS data analysis, the need for robust quality control, and the critical impact of accurate HLA typing on patient care, particularly in transplantation. Ensuring compliance with ASHI standards requires meticulous attention to detail in every step of the workflow, from sample handling to final reporting. The correct approach represents best professional practice because it prioritizes comprehensive validation of the entire NGS workflow, including bioinformatics pipelines, before routine clinical use. This aligns with ASHI emphasis on the analytical and clinical validation of laboratory methods to ensure accuracy, reliability, and reproducibility. Specifically, ASHI guidelines mandate that new methodologies undergo rigorous validation to demonstrate their performance characteristics, including sensitivity, specificity, and concordance with established methods, before being implemented for patient testing. This proactive validation minimizes the risk of erroneous results that could lead to suboptimal donor-recipient matching and adverse patient outcomes. An incorrect approach that relies solely on vendor-provided software without independent validation fails to meet ASHI requirements for laboratory-developed tests or significantly modified commercial assays. This is a regulatory failure because it abdicates the laboratory's responsibility to ensure the suitability and accuracy of the tools used in patient care. Ethically, it compromises patient safety by introducing an unacceptable level of risk associated with unverified analytical processes. Another incorrect approach that involves implementing NGS for a limited set of HLA loci without a clear rationale or a plan for future expansion overlooks the comprehensive nature of HLA typing, required for solid organ and hematopoietic stem cell transplantation. This is a professional failure as it may not provide sufficient discriminatory power for all clinical scenarios, potentially leading to incomplete or misleading information for transplant teams. ASHI standards expect laboratories to offer comprehensive HLA typing that meets the needs of the clinical setting. A third incorrect approach that skips post-implementation performance monitoring and ongoing quality assessment is also professionally unacceptable. This represents a failure to adhere to ASHI requirements for continuous quality improvement and proficiency testing. Without ongoing monitoring, subtle changes in assay performance or data analysis can go undetected, leading to a gradual degradation of accuracy and reliability over time, which is a significant ethical and regulatory concern. Professionals should employ a decision-making framework that begins with a thorough understanding of ASHI accreditation requirements and relevant guidelines. This framework involves a phased approach to implementation, initial method development and validation, followed by rigorous analytical and clinical validation, and finally, ongoing quality assurance and performance monitoring. Any deviation from this structured process, particularly in skipping critical validation or quality control steps, introduces unacceptable risks and violates professional and regulatory standards.